So we have a 45-year-old male with recent diagnosis of diabetes, and in the previous history we noticed dyslipidemia. Recently he was admitted in our hospital because of an infraposterior ST elevation myocardial infarction. Angiography revealed a two-vessel disease with a culprit lesion of the left circumflex. It was treated with primary PCI, being thrombus aspiration and implantation of 2 drug-eluting stents. And there was an LAD diagonal bifurcation lesion we will be treating now. After the myocardial infarction, there was normal left ventricular function. So here you see the images of after PCI of the circumflex, and you already see the lesion of LAD and diagonal. Next slide, please. So it's a Medina 111 lesion with long and tight involvement of the diagonal branch, unattractive for provisional technique, and its 2-stent strategy seems mandatory. What's our procedure plan? The patient is pre-treated with prasugrel and aspirin, and he receives heparin per procedure. We use a routine transradial approach with 6 French sheet that has been switched for a 7.5 French Asahi OCAT sheetless guiding. We plan to implant a Tryton side branch stent in the bifurcation with DES in diagonal and a DES in the main branch with final kissing balloon and IVUS. And as we already said, we plan to implant a Tryton side branch stent. It consists of 3 zones. The first zone in the side branch, then a transition zone which covers the ostium, and a main branch zone with minimal metal to artery where you integrate your DES in main branch. So in combination with a workhorse DES, it provides a nice scaffolding, and it's sort of a culotte stenting of a complex bifurcation without the excess of metal in the proximal part. And since you start the procedure by securing the side branch, we think it results in a more relaxed intervention. Next slide, please. Here you see the results. This is the 6-month follow-up of the E-Tryton Benelux, and as you can see, we have low MACE rates and especially low TLR rates. So I think this is a very interesting case, and let's start with the procedure, please.
Yeah.
So can we look? Do you have some setup shots of your bifurcation? I mean, you called it a 111. You might be able to argue that it's a 001. And that, I mean, there's a little bit of stenosis, it looks like here, just after the bifurcation, which is about a 30% angiographic stenosis.
Yeah.
But I'd be, most of the disease is obviously in the bifurcation. Do you have an LAO-cranial? We could see that in another view.
Yeah, the LAO-cranial, I think, is coming up there. It doesn't twist out that well. But as you can see on the slide areocranial, there is about a 50% lesion on the still frame that you can see on the image now, distal to the bifurcation. There is some disease proximally as well. So we weren't very comfortable in just stenting the diagonal in itself and being provisional on the main branch. The main branch needs to be treated as well, given the large territory that you have. And then we prefer a 2-stent technique, especially given the long length of disease in the diagonal branch. And we're going to have to use the Tryton stent. We pre-dilated already into the diagonal branch, and now we're putting a stent into the diag itself, and then we'll end up finishing off the bifurcation into proximal LAD with a Tryton stent, and then putting in a long DES in the main vessel in the LAD itself.
So the Tryton stent's a very interesting device.
It is,
of course, a bare metal stent, but it seems as if the outcomes, even the angiographic outcomes, have been very good in the side branch. It's about to start a large randomized trial in the United States.
Yeah,
we don't have it available right now, so I might ask Pat Whitlow. Pat, how would you have approached this bifurcation with what we currently have in the U.S.?
Yeah, I think the diag is a very big vessel and very diseased, not just idiopathic. Yeah. So I think the diag, rather than doing provisional stenting, which is our usual, I think I would have to stent the diag first. The disease in the LAD after the diag is also significant and likely to get shifted when you put that osteostent in. So I think it's a 2-stent technique, no matter how you do it.
No, I think in this case, I think the Tryton is an idea to use. We have used in Brussels now more than 60, and I can tell you the results are pretty good. And also the fact that the side branch stent is not a DES stent, With the bare metal stent, the in-stent restenosis is very, very low.
Yeah, I think
the effect of bare metal stent has a lot to do with how much plaque there is and how severe the lesion. I wonder in these side branches, are some of them covered? And maybe the stenosis is not so severe. In this one, it is severe. But
yeah, I think that's why you need to do this in the confines of a carefully controlled, randomized trial. But it's more like a culotte technique. It's a different technique because you're doing the side branch stenting first, and it's really opening up a channel to the side branch. It's not putting all the metal in the side branch like we've seen with other techniques. So it may be very low. You've pre-dilated, so show us what you're doing now.
So we've pre-dilated, which I routinely do because the Tryton stent itself, going forward into the vessel, performs exactly like any other stent that you're used to. But given the design, if you have to bring it back into the guide catheter, especially through a tight lesion, there is not a lot of metal in the proximal part. So I tend to pre-dilate routinely before I put a Tryton stent in. What we've done now, the Tryton stent has the 4 markers on the balloon delineating the 3 zones of the stent. Between the distal 2 markers, in the diag, you have a regular cobalt chromium stent which will scaffold the proximal part of the diagonal sufficiently. In between the 2 central markers, you have the transition zone, which is made to be able to expand to create a step up to the larger diameter of the main vessel, and it creates the space to recross your stent towards the main vessel, so for the culotte. Between the proximal 2 markers, you have the main vessel zone, which actually just consists of 3 struts and what they call a wedding band, which is just a proximal ring, 2 proximal rings now to keep it a little stronger, to minimize the amount of metal, but to stabilize your position while working anyway. So what we do is position the stent with the bifurcation itself in between the 2 central markers, and you actually have quite a lot of margin there. You have a transition zone of 5 millimeters, which is reasonably comfortable to position for you, and then we just deploy at 10 atmospheres. As you can see, this is a stepped model. We have a 3.5 millimeter proximal size and a 2.5 going into the diagonal branch. And you see that the step down of the balloon size occurs within the transition zone, well opening your bifurcation towards the main vessel. Alles goed? So this is well deployed now.
So this is a 3.5 that steps down
to a 2.5.
How many different options do you have?
For the moment we have 3.5, 3.0 and 2.5, all going to 2.5 distally, all being 19 millimeters of length. So that limits us for the moment for the treatment of very large vessels. It limits us for the treatment of very large side branches, but you can expand it up to 3.0 in the side branch and 4.0 in the main branch. And there are shorter versions and larger versions apparently coming up, especially for the treatment of very proximal disease and left main disease. We've done quite some left main cases with this, and in case of long left mains, this is a very easy way to do. The comfort that you have is that you've secured your side branch from the beginning of the procedure, and you don't have to worry about it in the end. If you have a large side branch, as you see here, this side branch is clearly stented, it's finished off now. There's a 2.25 millimeter stent in the mid portion, and then there's the Tryton stent going up there. What we're going to do now is put a larger balloon on the side branch wire just to optimize proximally before we have to recross. And then normally you quite easily drop the side branch wire. Since the side branch is secured and stented, you can just drop it into the main vessel, dilate again, and recross with a workhorse drug-eluting stent. I'm just waiting for the balloon now.
Another issue, of course, is that when you have a real bifurcation and severe disease proximally, now you'll be putting a DES inside a bare metal stent. So again, we need a randomized trial.
Yeah.
I don't know that DES works as well acutely if it's inside a bare metal stent. It very well might, but we've got to find that out.
Yeah. Well, the experience that we've had, there's been a few registries in the Benelux. Yeah. Where we've seen quite good results at 6 months. In the IDE trial that we're doing now, we're doing routine IVUS in these patients. Rotterdam has done a series of, I think, 50 patients with routine IVUS. And since there is so little metal in the proximal part, you actually see a well-opposed DES there. In the follow-up of the registries that we've done, we haven't had any instances of stent thrombosis, and the MACE rates actually compare well to the DES trials that we see in straight vessels. So in standard...
When you speak about the registries and MACE rates, you're talking about
clinical follow-up.
ELR, right? Not angiographic follow-up.
No. Clinical, of course. But many
clinical, not angiographic follow-up. And henceforth, the trouble with all
there's I think you've got to take all this registry data with a real circumspect view. There has been some angiographic follow-up, and I will say so far the data looks very good.
Yep.
But we've just got to see what it looks like.
We got to wait for the trial.
Trial with routine, systematic angiographic follow-up. Okay, thank you.
So hi, we're already done here. As you can see, we've lost our aprons. Patient is just getting off the table now, and he'll walk to his bed, as you can do with transradial approach. We'll show you the final results. I don't know if you can see the angio now. This is the final angio after kissing balloon. So you can see well-expanded stents in both vessels. We did a little post-dilatation of the distal stent in the diagonal branch on IVUS guidance, and we'll pass the floor to our good friend and co-worker Stéphane Carlier for the IVUS interpretation. Some of you apparently know him.
I think that you have the IVUS image now, and we are starting actually the pullback from the distal diagonal. You see that this is a vessel that is 2.5 in diameter, and at this level we see a small bifurcation and some more plaque. The distal diagonal was pretty nice, and we see the transition of the stent that was put there, and there was actually between 12 o'clock and 3 o'clock some suboptimal apposition, so we went for post-dilatation based on this. But more interestingly, you will have to follow the wire artifact at this level, and we just passed by the overlap of the Tryton stent that we are now examining, and we will approach the bifurcation that you can see coming once you will see exactly two wires coming in the image. At this level, the Tryton stent was very well expanded at the same size as the more distal stent. And the transition, please pay attention, you have a small side branch from the diagonal here, and at 9 o'clock is the diagonal coming, and you can see here the wires in the LAD that will plunge more deeply, and you see the expansion of the stent, and at a few times the superposition of the Tryton structure and the stent that is then in the LAD, and you see that the proximal is stopping just at the ostium of the LAD. We have the left main coming in the picture now with the circ that was coming. And I think that after the post-dilatation in the diagonal, we just went for one run in the LAD, and geographically the diagonal was looking good, and you will appreciate on this pullback now the distal LAD that was with some pinching from, I think, a short myocardial bridging at this level. You see the systole-diastolic change, and you have some eccentric plaque at this level. This is an LAD around 3.2 millimeter in diameter, and you see a perfect distal apposition of the stent. The area minimal there was around 7 millimeter square, and you see that this biometric stent is very nicely concentrically well opposed. And we will again come to the level where there will be the bifurcation. At this level there is the diagonal coming at 4 o'clock, and you can see the wire from the diagonal, and you see again perfectly appositioned proximally. And pay attention, we are here at 40 megahertz with a kind fine resolution. You can see the two layers of struts, for example, at this level of the arrow. More proximally, the stent was expanded to up to 9 millimeter square. You see again the bifurcation here with the circ coming at 2 o'clock, the two wires here, and the left main. So if here there is very few metal in the way here, that's very nice results. Better than the culotte that we were trying to do.
I think the bifurcation looks beautiful, Stéphane. The bifurcation looks beautiful, and I want to congratulate you. I think very nicely showed the potential for this new device.